We're very pleased to have Dr. Paula Gordon joining us from Vancouver this evening. Some of you may know Dr. Gordon as being part of the Goldenberg family, who are founding members of Beth Torah congregation. Dr. Gordon is a clinical professor from the University of British Columbia and is an expert on breast cancer screening. So welcome, Dr. Gordon. Thank you so much for being here. I'm going to mute myself, and then we can move ahead with the lecture and again to Q&A afterwards. So thank you.
Thanks, Atara, and hello, everyone. Big thank you to the Beth Torah congregation for hosting this lecture. I'm going to explain what optimal breast cancer screening involves, and I realize there may be people watching from elsewhere. Because Beth Torah is in Toronto, I'll be referring primarily to the situation in Ontario, but I'll include other provinces and the United States. No province achieves the ideal, and I'll explain why, and I'll show how advocacy at the grassroots level can succeed. Now we have to get this to go. There we go. And here are my disclosures. I'm here on a volunteer basis, and I have no sponsorship. The data I will show you are from the scientific literature, and they're not just my opinion. Today, I'll start by discussing what age is best to start screening and how often. I'll talk about why and how we try to find breast cancer as early as possible and what the benefits and the possible risks are. I'll explain the politics that impact medical policies, why the best methods are not offered, and suggest what you can do to advocate for yourself. So let's review. What is breast cancer? It's a disease where a group of cells loses normal control. Those abnormal cells grow, usually into a lump, but not always, and they invade and damage the nearby normal tissue. They can spread to other parts of the body, usually first to the lymph nodes in the armpit, but then to other organs like the lung, the bone, the brain, liver, etc. Many breast cancers can be found before they have spread, and when they are, women are less likely to die, and they can be treated less aggressively. Breast cancer can be present before there's a lump, before it's visible or even feelable, but left untreated, it can lead to dimpling or a bulge in the skin of the breast, and it can even ulcerate, as you see here. Mammograms and other tests can find cancers before they grow large. These examples are of 3 different cancers in different women. What you're seeing is the side view of the left breast. The 2 cancers on the left, this one and this one, were found on screening mammograms. The one on the right was in a 47-year-old woman who found a lump. Her mammogram shows at least 2 cancers occupying a large proportion of her breast. Breast cancer is not life-threatening if it's just in the breast. It's when it spreads beyond the breast that it can become lethal. You've heard that 1 in 8 women get breast cancer, but that's not in every age group. Breast cancer is very uncommon, but still occurs in the 20s and 30s. Only 1 in 1,700 in women in their 20s and 1 in 228 in women in their 30s. The incidence jumps dramatically at age 40, up to 1 in 69, and it keeps rising. It never drops. Women sometimes tell me that they don't need a mammogram now that they're 60 or 70 years old. But unless a woman dies of something else, her risk of breast cancer keeps climbing. Women are not all at equal risk of getting breast cancer. There are factors that can increase a woman's risk, many of which are beyond our control. And those are listed on the left here. Ashkenazi Jewish women are at higher than average risk. Genetic mutations, like the BRCA gene mutations, previous chest wall radiation, usually for treatment of Hodgkin's disease, dense breast tissue, which we'll talk about later, having a family history of breast cancer, having atypical cells on a previous biopsy, starting menstruation at a young age, and finishing with menopause at a later age, and not having any children. All of these increase the risk of getting breast cancer. The list on the right is a list of factors that you can control to reduce your risk. Using minimal or no estrogen after menopause, consuming no alcohol or limiting your alcohol, following a low-fat diet, exercising moderately, not smoking, getting to and maintaining a healthy body weight, all of these reduce the risk of getting breast cancer. But please remember, we are all at risk. The biggest risk for getting breast cancer is being female. And the second biggest risk is getting older. So some women tell me they don't need mammograms because no one in their family has had breast cancer. The fact is, 75% of breast cancers occur in women who have no family history and no other risk factors. Why do we screen for breast cancer? Well, for two reasons. The first, of course, is to save lives, but also when we find breast cancer earlier, women can be treated with less aggressive therapy, and we'll talk more about that later. There are several tests that can be used to screen for breast cancer. I'm going to focus on mammography and ultrasound, but I will discuss the other tests later as well. Let me be clear. Thermography has been thoroughly discredited. It can find big cancers close to the skin, but those aren't a problem for us. It misses the smaller cancers and cancers deeper in the breast, and it has loads of false positives. So here are the facts that everyone agrees on. This and the next slide might be the two most important things for you to remember in this talk. Women who have screening mammograms are 40 to 60% less likely to die of breast cancer than women who don't have mammograms. And another fact, annual screening starting at age 40 saves the most lives. In fact, even organizations that recommend starting later and doing mammograms less often, they know this to be a fact. Yet the current guidelines of what age to start and how often to screen vary widely. And these different recommendations don't arise because of a disagreement on the facts. Those facts are true and agreed upon. The recommendations vary because of different value judgments applied to the same facts. So you need to know, and that's what I'm going to explain to you tonight, you need to know what those value judgments are to see if they align with your values and your priorities. Here's the evidence that screening mammograms save lives. This is a list of the mammogram studies called randomized trials done worldwide. They were done to find out whether mammograms could find cancers early so they could prevent deaths from breast cancer. And notice that these trials are 30 to 50 years old. And so for the rest of the talk, I'm going to refer to these as the old studies. High quality is essential for mammogram accuracy. The mammogram on the left is taken in Canada in 1980, and you can see how blurry it is. The one on the right was taken in Sweden around the same time. Even a layperson, you don't need to be a doctor to see the difference. Look at that difference in detail. And when mammograms are blurry, they can hide cancers. This one is from one of those old trials that was done in Canada. And not surprisingly, the results in Sweden in their old trial was much better than the results that we got in the Canadian old study. And even though that study was done between 35 and 40 years ago, the damage to screening policy is ongoing. Every time they release updates, women phone in and cancel their mammogram appointments. This article in the Globe and Mail was about the release of the 25-year follow-up of that Canadian old study. I and many others internationally are painfully familiar with the details of that trial and have to stay on guard to respond every time this happens. In fact, in 2002, the World Health Organization recommended that this Canadian trial not be used in making future guidelines. But both the American and the Canadian task forces that issue screening guidelines still include it. And the Canadian task force used it in their guidelines that they released in December 2018. So who are these people? What's the Canadian task force? It's a committee that makes screening recommendations. For their breast cancer guidelines, the chair of the committee is a psychologist specializing in a skin disorder called scleroderma. There are family doctors and epidemiologists. There's a chiropractor and an occupational therapist, but there's no breast cancer expert. This is the committee that's making our screening recommendations. They're funded by the Canadian Ministry of Health through the Public Health Agency of Canada, but at arm's length. And as a result, they are not accountable for their recommendations. They decided to refer only to those old studies I showed you, all 30 to 50 years old, and they included that Canadian trial with all its flaws, and they concluded that women should start having mammograms at age 50, that they should have them only every 2 to 3 years. They also recommended that nobody needs any special screening with MRIs except maybe women with breast cancer mutations, a BRCA gene. And the American Task Force is similar composition, and their recommendations are almost identical. That, by the way, they also recommend that women don't do breast self-examination, and they say that doctors shouldn't do breast exams during a physical. So here's one of the studies they chose to ignore. This is a study from Canada, obtained on almost 3 million women attending screening programs throughout Canada. And they compared the women who had mammograms to the women who didn't, and showed that women who have screening mammograms are overall 40 to 44% less likely to die of breast cancer than those who don't. The Swedes published a major paper last year looking back at 58 years of data in one Swedish county. And they showed that women who chose to be screened were 60% less likely to die in the first 10 years after their diagnosis, and 47% less likely to die after 20 years of diagnosis than women who didn't have mammograms. And this year, the Swedes updated and extended the study to over 500,000 women in 9 counties. And they showed that women who have mammograms are 25% less likely to be diagnosed with an advanced cancer, and that they're 41% less likely to die of breast cancer within 10 years of their diagnosis. Now, some say that because we have better chemo drugs now, that it's not important to find cancers early. And that's not true. These modern studies I just showed that even with better treatments, women who've had mammogram screening have better outcomes than women who don't go for mammography. The task force has only used data from those old studies to decide whether mammograms are beneficial. But those old studies were designed to only show whether they decrease the deaths, and they do. But there are other significant benefits of early detection that were not considered by the Canadian or US task forces. Here's a big reason. When cancer is detected early, women can avoid a mastectomy and have a lumpectomy. That's a really good reason to find cancer early. Here's what lymphedema looks like. It's a swelling in the hand and arm from blockage of the lymph vessels in the armpit, and it's a side effect of the traditional armpit surgery done as part of breast cancer staging. I suspect many of you may be nodding your heads either because you have it or you know someone who has it. It's permanent, and as you can imagine, it's life-changing. It's arguably the worst part of breast cancer for many women. But when breast cancer is detected early, women can now have what's called a sentinel node biopsy instead of the bigger armpit surgery, and it has a much lower incidence of lymphedema, which is another reason to find cancers as early as possible. And as I said, the task forces ignored this. Chemotherapy is awful, but unlike lymphedema, most of the side effects are temporary. But now with genomic testing of the actual tumor, many women can avoid chemotherapy if their cancer is small and if there are no positive nodes. So here's another reason to find cancer early. A group of researchers in New York showed that women who have screening mammography less often are more likely to need mastectomy, more likely to require the bigger armpit surgery, and more likely to need chemotherapy. Now, the various organizations that do not support annual screening starting at 40 point out that there are some risks, they call them harms of screening, and that these outweigh the benefits. They must be pretty significant harms to outweigh saving lives and avoiding harsh treatment, don't you think? So let's look at them and see if you agree. Number 1, pain from compression. Yes, mammograms are uncomfortable, and they should be, but they shouldn't be excruciating. The reason we compress is to use less radiation and spread out the tissue so we can see better, and that includes seeing cancers. The discomfort is literally for a few seconds, and you can tell the technologist to stop if you can't tolerate the compression. Better a slightly undercompressed mammogram than no mammogram at all. Next, let's talk a little about radiation. I know it's a concern for some of you, but notice it's not a concern for the task forces. It's hardly on the list. You'll see why. Now, You may not know it, but there's radiation all around us all the time. Natural background radiation comes from the sky. The sun and stars send cosmic radiation to Earth, and the amount varies with elevation. The ground, radioactive materials exist naturally in rock and soil. Even the air, all air contains radon, which is the greatest natural background source. And even water contains small amounts of dissolved radioactivity, and all organic matter, plant and animal, contains radioactivity. The risk of radiation for breast cancer, from a mammogram rather, is primarily in women less than 20 years old. The dose of a mammogram is similar to taking 5 flights from Toronto, Vancouver. That's something I do a lot. Not many of us worry about radiation when we're booking a vacation, but it's there anytime you go up in a plane. Also, natural radiation is greater at higher elevation. Do we think about radiation when we drive up to Whistler and ski from the top, or visit Denver? Most of us don't think about it, but we are exposed to higher radiation at elevation. This graph is from an excellent website called densebreastinfo.org, and it shows the radiation from various medical tests. The lowest dose you can see down here is bone densitometry and a chest x-ray, and a mammogram is the 3rd lowest. The blue vertical line on the right is the amount of radiation that is safe for radiologists and technologists to get during the course of their work every year. And it's 12 times the dose of a mammogram. So don't worry about radiation. False alarms. They're the biggest harm in the eyes of the task force. That's when a woman gets called back after a screening mammogram for more tests. But here are the numbers. For every 1,000 women who have screening mammograms, 930 will get a normal result. 70 of them will be recalled. They'll get a letter saying you need to have some more tests. 70 will have the tests, and the majority of them will only need maybe 1 or 2 extra mammogram pictures or maybe an ultrasound. 11 of the 1,000 will need a needle biopsy, and those are done with local freezing and should not be more painful than a blood test from the arm. And 4 of the women who have needle biopsies will be diagnosed with cancer. So that's 4 out of 1,000 on average. The task forces think that we should spare women the anxiety of a false alarm. And that's why they recommend starting screening later and screening less often, even though they know that more women will die. Do women think that false alarms are a reason to not recommend screening? Researchers in Pittsburgh studied this. They surveyed all women attending for routine screening over a 5-month period, and 1,570 of them responded. 97% said that they would still have regular mammograms, even if it meant having a false alarm. 86% said they'd be willing to be recalled more often for more tests. And 82% said they'd be willing to have a needle biopsy if it might increase the chance of detecting a cancer early. So that's what you have to consider when you decide whether to have a mammogram. Remember, 4 of those 11 needle biopsies show cancer, and generally it's an early cancer. This comic sums up the task forces. If you can't see it, it shows a doctor standing at a gravesite looking down, and he's saying, yes, mammograms and early detection would have saved your life, but aren't you glad we spared you all that anxiety? Excuse me. The anxiety when a woman is recalled for tests is real, and it can be really, really hard, but it's transient. Women are strong, and they can tolerate some transient anxiety, and it should not be up to a committee of non-experts to decide that she shouldn't be able to have mammograms and that she should lose the opportunity to diagnose cancer early. You need to know that's the main reason that some places don't start screening till age 50 and screen only every 2 years, even though more women will die. And if you disagree with that, speak up. I will give you some links to websites that you can use to advocate for yourself. Another harm of screening is overdiagnosis. Now, this is a tough one to get around your head around. It's a theoretical possibility that some cancers we find at screening would never surface on their own, and so there's really no need to know about them. It's probable that some cancers we find do grow so slowly that they may never become life-threatening, but we don't know yet how to recognize them. Or it's possible that a woman might die of something else before her cancer becomes life-threatening, like heart disease, a different cancer, a car accident. The likelihood of overdiagnosis in younger women is almost zero because they're less likely to have other diseases. The challenge is that most of us don't have a crystal ball. If you knew that you were going to be killed in a car accident tomorrow or die of a stroke 6 months from now, then you wouldn't need a mammogram. Dr. Helvey from Michigan summed it up beautifully. I won't read the whole thing, but the last sentence is the key. Many women are willing to accept screening risks in order to reduce the likelihood of dying of breast cancer. So as I said, if you agree with that, if that's your philosophy, then you should speak up and advocate for yourself. The Canadian and US task forces think the harm of transient anxiety outweighs the benefits of early detection. They recommend no screening till age 50. The US says do mammograms every 2 years after 50. The Canadian task force says every 2 to 3 years. And they both say that doctors should stop doing breast exams as part of a physical and that women don't need to do breast self-exams. Well, if you're not doing mammograms, you're not doing breast self-exams, and your doctor's not checking your breasts, when are we going to find your cancer? When it's so big you can see it bulging through your t-shirt? This comic from the Vernon newspaper sums up their recommendation for women in the 40s. Don't worry your pretty little heads about it. They think we should have overdying instead of some transient anxiety. These are the value judgments I spoke of earlier that explain the differences in screening recommendations among different organizations. The task force came to their recommendations by using the old studies, by understating the benefits and over-exaggerating the risks. They think we should have overdying. When the US task force released their recommendations, doctors Hendrick and Helvey calculated that if women followed those recommendations in the United States, 100,000 more of them would die every year than if women started screening annually at 40. So, when to start? In Ontario and 6 other provinces, screening mammograms aren't offered to women in their 40s, but here's some important facts showing why it is important to start at 40. 1 in 6 breast cancers is diagnosed in women in their 40s, and 41% of the years of life lost to breast cancer are in women diagnosed in the 40s. The End the Confusion website has references and lots more information you can share. Women in the 40s are often caring for young children and aging parents. They're working and they're contributing to the economy. They are not expendable. They deserve to be screened. All women in Canada should have access to screening starting at age 40, ideally annually, but only 3 provinces start at 40. And annual screening would save the most lives, but none of the provinces offers screening annually to all women. Even the Canadian Task Force agrees that it would save the most lives, but they think it's more important to save women the anxiety of a recall. When should screening stop? This life expectancy chart is from Statistics Canada. The average life expectancy for a 75-year-old woman is 13 years. At age 80, it's 10 years. The American Cancer Did I get muted? I can't hear you. Should I just start on this slide, or
You're
do you
fine
want
now. Start back on this slide. I think you may have hit something. Sorry.
I didn't touch it. Okay.
You're good
No
now.
worries. Okay, so this slide is from Statistics Canada. The average life expectancy for a woman who reaches 75 years is 13 more years, and at age 80, it's 10 years. So the American Cancer Society recommends that women keep having mammograms as long as their life expectancy is 10 years, which means screening till age 80 is reasonable. But it depends on your general health and your personal values. If you've got really bad diabetes and heart disease and you're 70, you may want to stop screening then. But I have a friend who's 84 and extremely active. She just bought a road bike last year and rides 10K 3 times a week, and she's still having mammograms. Okay, so now what do I have to do? The old studies included women only up to age 74, so the task forces recommend stopping then. And many places have defaulted to that, but some places stop screening at age 69. But if a woman's in good health with a life expectancy of 10 years and is well enough to have treatment if we find a cancer, then it's worth continuing to have screening mammograms so we can find cancers when they're small. If those cancers aren't found and they grow large enough to be found as a lump, then more extensive surgery will be required. And for some women, by the time they can feel a lump, they'll be older and they may not be in as good health, and they may be less able to have treatment. So these are two of the many studies that showed that in these practices, up to 10% of the screening mammograms were in women 75 or older. They showed a high number of cancers in this age group, between 6 and 8 cancers per 1,000 women, and most were invasive. And 98% of these women went on to have surgery. So now many organizations recommend, and I agree, that an individual woman's decision to continue screening should be based on her health, her life expectancy, and her values. So switch now and let's talk about breast density. We're pretty good at recognizing what cancer looks like on a mammogram when it's visible. Here's an obvious cancer in a 55-year-old woman. The reason I know that it's cancer is because it has jaggedy edges, and because of these tiny white dots you hopefully can see there, which are suspicious calcifications. And it's easy to see the cancer because it's white and the rest of her breast is dark gray. It's relatively easy to see cancer when the breast is mainly fatty, like in this woman. Fat is dark gray on a mammogram. If she had the cancer that I showed you a couple of slides ago, it would be pretty easy to see in her fatty breasts. Here's another woman. These breasts are also normal, but they're not all dark gray. There's a lot more white tissue, and that's normal breast tissue. And white is the opposite of fat, and we call it dense because it blocks the passage of X-rays through the breast. We'd have a good chance of seeing that cancer in these breasts. But these breasts are normal too, and they have even more normal dense tissue. It becomes harder to see cancers which are white, like trying to see a snowball in a snowstorm. It would be challenging to see cancer in her breasts, but it's hiding there. And some women have virtually no fat, and they're all dense. These breasts are extremely dense, almost no fat. Even a large cancer could be missed in this woman. It would probably be impossible to see that cancer from the other slide in her breasts. Mammograms find 98% of cancers in women with fatty breasts, but less than 50% in women with the densest breasts, even with modern digital mammography. So let that sink in. We miss 50% or more cancers in women who have the densest breasts. So for women who do have dense breasts, it's potentially harmful for them to not know their breast density, because if they're told that their mammogram's negative, it can give a false sense of security. And you probably all know of women who ignored a lump because they'd recently had a negative mammogram. So let me be clear about using the word negative. I know it sounds like negative might be a bad thing, but with medical tests, negative is a good thing. Like if you have a test for COVID and you test negative. Even important people get confused with the word. And in case you haven't come across this hilarious comedian, her name is Sarah Cooper. Let's see if this works.
And I tested very positively in another sense. So this morning, yeah, I tested positively toward negative, right? So no, I tested perfectly this morning, meaning I tested negative.
So a negative mammogram, let me get my zoom back here. Here we go. So a negative mammogram is a good thing. It means that we don't see anything suspicious. With mammograms in women with dense breasts, it's not always accurate, but it's still a good thing. This animation shows why we say that looking for cancer in a dense breast is like looking for a snowball in a snowstorm. How a small cancer easily seen in a fatty breast can be hidden in normal dense tissue. Radiologists divide density into 4 categories, we call them A, B, C, and D, in the breast imaging, reporting, and data system called BI-RADS, which was created in the 1980s. Categories C and D are called dense, and A and B are non-dense. Breast density can sometimes decline as a woman gets older, but not always. There are young women with fatty breasts and elderly women with dense breasts. Ontario is one of 2 provinces still using a much older 2-category system of greater than or less than 75%. And that's worrisome because women in category C are misled into thinking that they don't have dense breasts. I think Ontario is going towards the 4-category system soon. Here's an example of dense tissue hiding a cancer. This woman's actually an acquaintance of mine, and she had a negative screening mammogram at age 50. But negative, remember, in a woman with dense breasts doesn't always mean no cancer. 8 months later, she came back because she felt a lump in her left breast. And you can see the triangular sticker that the technologist taped to her skin right over the lump. We repeated the mammogram and it was negative. Even with 3D mammography, it was still negative. But when we did her ultrasound, we had no trouble seeing her 3.2 centimeter cancer, and it had already spread to her lymph nodes. When cancer is diagnosed after the most recent screening mammogram was clear, it's called an interval cancer. And interval cancers are 18 times more common in women with dense breasts. We see cases like this every single week. But here's the thing. Dense breasts are normal and common. Every woman has fat and breast tissue in her breasts, but the proportions vary from woman to woman. If the breast has more than 50% glands and fibrous tissue, we call them dense. And more than 40% of women aged 40 to 74 have dense breast tissue. Sometimes, as I said, they can become less dense with age, but not always. So while it's normal to have dense breasts, women need to know if they have dense breasts so they can understand the implications. In Canada, there are 3.4 million women over the age of 40 with dense breasts, and over 800,000 women in Canada have the densest category breasts. So here's why it's important to know if you have dense breasts. Women in the D category are 5 times higher risk of getting breast cancer than women who are fatty. Dense tissue and cancer both appear white on a mammogram, so cancer can hide in normal dense breast tissue. When women have dense breasts, are diagnosed with cancer, they're more often larger cancers and they're more often already spread to the lymph nodes. And as I said, they have 18 times higher risk of an interval cancer, and interval cancers have a poorer prognosis than screen-detected cancers. Breast density can only be determined from a mammogram. You cannot tell by feel. Your GP can't tell by doing a physical exam, and you can't tell by doing breast self-exam. Both fatty and dense breasts can feel soft, they can feel firm, or even lumpy. Most often, breast density is judged by the radiologist just by estimation when we look at the mammogram, but some provinces are starting to use software to measure the density, so it will be more objective. I showed you already an example of how ultrasound could easily see a cancer in the woman with dense breasts when it was missed. We published this paper 25 years ago, and it was followed by work from multiple other institutions and multi-center trials that showed that high-resolution ultrasound can find cancers that are too small to be feelable and that are missed on mammograms, largely because of dense breast tissue. This trial recruited 2,800 women who were at elevated risk for breast cancer, and they did ultrasound in addition to mammography annually for 3 years. The ultrasound found an additional 5.3 cancers per 1,000 women in the first year, and an average of 4.3 cancers per 1,000 women over the 3 years of the study. These were cancers missed on their mammograms, and 94% of them were small, invasive, and 96% of them had not yet spread to the lymph nodes. So these are the cancers that can be treated less aggressively. Ultrasound can be done with a handheld probe like this, or a large probe that automatically scans about 1/3 of the breast. It's called ABUS, ABUS, Automated Breast Ultrasound. It's available in some clinics in Ontario, 2 in Toronto and 1 in Barrie, and many in Alberta. Any ordinary ultrasound machine like this can be used to do breast ultrasound, but not all clinics offer it. And you might have trouble getting your family doctor to refer you for a screening breast ultrasound. Breast density advocacy starts with this woman. In spite of all the emerging evidence on breast density, it was still not being shared with women, and in many cases with their doctors. Dr. Nancy Capello was a PhD in educational leadership in Connecticut. In 2004, Only weeks after having a negative mammogram, she found a lump in her breast. And when she had the ultrasound and needle biopsy, they diagnosed her with a stage 3C breast cancer with 13 positive nodes in her armpit. Her doctors insisted that there was nothing to be changed in the system of breast cancer screening for women with dense breasts. And she said, the heck with that. And she lobbied for legislation to require patient notification of density and its impact on mammogram sensitivity and the potential for supplementary screening. She started a grassroots movement to get women notified when they have dense breasts. And since the medical establishment pushed her away, she went to the legislators, and there are now 38 states and the District of Columbia in the US with some degree of breast density notification. And the FDA has mandated that as of next year, all American women will be told their breast density when they have a screening mammogram. This map is from the densebreastinfo.org website, which I'll give you again later. Connecticut was the first state to pass that legislation, and they now have several years of data. They're finding an additional 3 to 4 cancers per 1,000 women screened. Those are women with category C and D density and no other risk factors. These are cancers that were missed on their mammograms, and they're almost all small, invasive, and node negative. And here's some examples from my colleague at Yale. Cancers found on ultrasound that were missed on their digital mammograms. We know from decades of research that mammograms save lives, but mammograms miss cancers in dense breasts. Why don't screening programs offer ultrasound to find those cancers? Well, they say that we don't know if finding those cancers will save lives because mammography is the only test that was studied in the old trials. Well, good news, that kind of trial is now being done in Japan, and early results suggest that it too will show fewer deaths from breast cancer. MRI is done for women at very high risk, but there's never been a trial to show that it saves lives, which raises the question, why do some tests need a trial and others don't? And do we really need a new trial for every test? I and many others say no. We learned from the old trials of mammography that the reason lives are saved is by finding small cancers before they've spread to the lymph nodes. So any other test that can find those kinds of cancers will also save lives. The cancer doesn't care how you found it, whether it was on a mammogram or an ultrasound. And I've already shown you that is the exact kind of cancer that the screening ultrasound finds. So insisting on a trial really, in my opinion, is stalling, and it's costing lives. But more good news. A group of women who've had breast cancer has formed an educational and advocacy nonprofit called Dense Breast Canada. They're active on social media. Facebook, they have Twitter in English and French, and a website. Thanks to their efforts, BC became the first province to notify women of their breast density when they have a screening mammogram, and that's as of October 2018. And BC health insurance covers screening ultrasound for women with dense breasts. Nova Scotia, Prince Edward Island, and New Brunswick are now notifying women, but still not covering ultrasound. Alberta has committed to notifying all women, and Manitoba is moving in that direction. But advocacy work in some provinces has stalled because of the pandemic. So grassroots advocacy is working. I think it works better than medical advocacy. I've been talking about ultrasound in dense breast for 25 years, but it's only taken Dense Breast Canada 3 years to lead to some really big beneficial changes, and there's more to come. Saskatchewan, Manitoba, and Ontario are only notifying women in the highest category. The problem with that, as I've told you, is that you might be in category C and not be told that you have dense breasts. So this information is slowly changing, and you can keep track by checking those websites that I will show you to find out what your state or province is doing. Here are the 2 websites, and the second one covers Europe as well. I'll give you a minute in case you want to jot this down. One is densebreastscanada.ca, and the other is densebreast-info.org. So here are some facts that even your doctor may not know. Women with the densest breasts are at 5 times higher risk to get breast cancer than those with fatty breasts. Having dense breasts is a stronger risk factor than a family history. Mammograms miss 50% of cancers in women with the highest density. But ultrasound can find cancers missed on mammograms in dense breasts. Your doctor may be reluctant to order ultrasound because they don't want to put you through the anxiety of a false alarm. So if you think you can handle some transient anxiety, tell them. Better safe than sorry. And think how anxious you'd be if you had a diagnosis of a late breast cancer. As for needle biopsies, I know they sound awful, but they really aren't. I always ask women when I finish their test whether it was as bad as they were expecting. And the best answer so far is a woman who said to me, Dr. Gordon, I have shoes that are more uncomfortable than that test. There are additional technologies emerging in helpful in dense breasts. You may have heard of 3D mammography, also called tomosynthesis or DBT. It's a better mammogram than the standard 2D. It finds about 30% more cancers than 2D and has fewer false alarms, but it's not yet being used in any of the screening programs in Canada. And even 3D mammograms, as I've already shown you, can miss cancers in dense breasts. MRI is the most sensitive test at finding breast cancer, but it's very expensive. It requires an intravenous injection and has lots of false alarms. In Canada, MRI screening is usually reserved for women who either have a breast cancer gene mutation or who've had chest radiation for lymphoma. Not all women can tolerate MRI, and there is some concern about using it for women who are not at very high risk because of the false alarms and because we don't know the long-term effects of the deposits of the injected material in the brain. There's a new way of doing breast MRI that's much faster. It's faster for the woman in the machine. It's faster for the radiologist to read the exam. And this test is being studied now. It's either called abbreviated MRI or sometimes fast MRI. If they can bring down the cost, and when the studies are complete, it might be used more often for women at average and higher than average risk, but we're not there yet. Another test is called contrast enhanced dual energy mammography, and it shows great promise. It finds almost as many cancers as MRI, but has fewer false alarms. It also requires an intravenous injection, but it uses a different injection material than is used with MRI, and this test is much less costly than MRI. In Canada, they are using this test in London, Ontario. There are 2 nuclear medicine tests that can find breast cancer. Both require an intravenous injection of radioactive material. So unlike mammography, which gives only low-dose radiation and only to the breast, this radiation is to the whole body and especially the pelvis. And that's a concern for younger women because the ovaries are in the pelvis and we don't want them to get radiated if women are still having children. The radiation from this test is 6 times higher than for mammograms. And the other weakness in this test is not good at finding lobular cancers. So for women who have dense breasts, including those who've had cancer who've had dense breasts, what should you do? Well, number 1, continue having mammograms because they can detect cancer that isn't visible on ultrasound. Do regular breast self-exams. Ignore the task force. Do breast self-exam and look for any change that might be cancer, even if you've just had a negative mammogram, and then go see your doctor. Consider modifying those lifestyle factors to decrease your risk of getting breast cancer or getting a recurrence, such as getting to and staying at a healthy body weight, doing moderate exercise, decreasing alcohol intake, and decreasing hormone use. And if you've had cancer in the past, that's an additional risk. Speak with your doctor. Consider additional screening like ultrasound or MRI. And if you've just been diagnosed with cancer and you know you have dense breasts, consider getting an MRI before deciding on whether you need a lumpectomy or a mastectomy, because the extra testing can sometimes find additional cancers that they don't know about. It can also check the other breast for hidden cancer. Here are the latest recommendations for breast MRI from the American College of Radiology. Breast MRI is recommended for women who have a breast cancer gene mutation or who've had chest radiation, usually for lymphoma. Also for women with dense breasts who've had cancer, they recommend MRI. And for women who've had breast cancer before age 50, even if they don't have dense breasts. And for women who've had a breast biopsy that showed atypical cells. So here's what I want you to remember, the take-home points from all this information. All women should have mammograms, ideally annually and ideally starting at 40, but certainly go as soon as your programs will allow and go as often as your screening program will allow. And maybe help advocate for screening to start at age 40 across Canada. Some cancers are not detectable on a mammogram, so it's worth doing breast self-exams. Get to know what your normal texture feels like so you'll recognize if it does change. Most abnormalities on mammograms are not cancer, so don't panic if you get recalled from a screening mammogram. Women who have mammograms are 40 to 60% less likely to die of breast cancer, so please have screening. 3D mammograms find more cancers than 2D mammograms, and they have fewer false alarms. And when you look at all the benefits of early detection by screening, the benefits outweigh the harms. Ultrasounds can find cancer missed on mammograms in dense breasts, even if 3D mammography is used. Having dense breasts poses two risks. The first is being at a higher risk of even getting cancer, and the second is letting cancers hide in dense breasts, so that reduces the accuracy of mammography. It's important to know your breast density and understand the implications, so please speak to your doctor about your risk factors. And finally, we know that screening saves lives, and we know it works best when done annually. Now, during the peak of COVID, the risk to women and mammography technologists outweighed the risk of breast cancer, but we're now 3 months behind with the pandemic closures. With flattening of the curve and availability of PPE, personal protective equipment, mammography is safe and should gradually resume. So it will not be full capacity right away. They're going to increase very gradually. We've resumed screening mammograms in British Columbia, but we're a little bit ahead of you on the curve. And Ontario is waiting for a decision from Cancer Care Ontario, but they're dragging their feet. It's been estimated, and these are approximate numbers, that if there's a 6-month interruption of breast cancer screening, and if the volume of screening resumes at 50% of normal when it does start, then in Ontario alone, there'll be 200 additional deaths in a decade and 273 additional deaths by 2050. If it takes a year to get back to normal volumes after the interruption, the number of deaths will be 242 over the next 10 years and 416 by 2050. So please consider adding your voice and tell your MPP that you need to restart screening now. So thank you all for your attention, and I'm happy to take questions. I think Atara is going to moderate those.